Okay, so this talk is going to be about a treatment that we offer here at San Diego Orthobiologics Medical Group for severe knee arthritis. It doesn't have to be just for knees. You can do it for other joints, but particularly we see knees quite commonly have these bone marrow lesions that we're going to talk about. And this is another option in our tool belt to try to help people along and avoid costly surgeries with a lot of comorbidities attached to them. So when we talk about arthritis, it's way more than just lack of joint space. A lot of people just think when you have arthritis, it means there's no space in between the bones. And that is true, but the cartilage that is on the outside of the bones really helps distribute the forces across that joint. And when you lose that cartilage, the forces have to go somewhere else. And that's where the subchondral bone, the bone that's underneath that outside portion of the bone, bears the brunt of the force. So it's really the shock absorber portion of the bone. So if we're talking about someone that has pain on the inside of their knee, it's going to be the medial femoral condyle, the medial tibial plateau. Those are the areas that we're going to see affected in the subchondral bone. And over time, you can see what we call bone marrow lesions. These are going to be bright white spots that get picked up on the MRIs, especially on fat suppressed images. So Dr. Sanchez and a few other doctors out in Spain did a nice study where they actually went into sheep subchondral bone. They injected methylene blue dye, and they injected this into the subchondral bone. And then they did an arthroscopy, and they were able to see the cartilage, and the cartilage had turned completely blue. So that was a really eye opener for me to see that because that really just drives home the point that a lot of the nutrients that are needed for the cortical bone, the cartilage, are all going to diffuse through these microchannels in the subchondral bone out to that cortical bone.
I'm going to interrupt you real quickly because a lot of our folks don't speak the lingo. Sub just means below, right? So subchondral means it's below and chondral means cartilage. So subchondral just means below the cartilage. And I like to tell my patients that if your cartilage is the lawn, the bone underneath is the soil or the dirt, the earth. And obviously you need the nutrients in the earth to feed the lawn. So I don't know if that works for you, Dr. Marker, but that's what I usually share.
For sure. Yeah, it's a great analogy. But yes, the it's usually about a centimeter below that outside of the bone. And I'll have some slides coming up that show some actual MRI images so that we can kind of show you where those bone marrow lesions occur. So it's really a stress reaction, and it's highly correlated with osteoarthritis and linked to pain. And it's an inflammation and microinjuries within that subchondral bone. So these are some MRI images, and these areas here, these bright white areas here, this is what we would call a bone marrow lesion, where you can see the cortical bone would be where the cartilage used to be, or there's still some remaining cartilage. But after you lose that, this is the area that's going to absorb a lot of the forces. And that's where you see these bright white areas. So around here too is a big, large bone marrow lesion.
So this is a knee, and the bone on top is the thigh bone, the femur, and then the bone below is the tibia, for those who don't look at MRIs every day. And normally the bone, I'm sorry, I keep interrupting you, Dr. Marker, but just gonna, basically, you can see the bone is normally, on most of these images, gray, but when it's inflamed or damaged, then you see that white signal that Dr. Marker was pointing out there. Yeah.
Yeah, we take, it's true, we look at these all the time. So it's, but for people that aren't reviewing several MRIs a day, it's good to have the visual and point out where things are. So why do these bone marrow lesions cause pain? Well, there's an increased pressure within the bone when they have them. And I was mentioning those little channels. It's a microtrabecular injury that happens within there. The bone has such tightly woven fibers in there that when you inject into the bone, that's really what hurts. And when we talk about these procedures, a lot of times when I broach the subject with the patient, they first flinch when they hear that you're going to go in and inject something in their bone. But it's really going into the bone doesn't really hurt. It's when you inject something in the bone because that pressure within the bone is so intense. So we've learned over the years that we really don't want to use large syringes because the force on that plunger is just going to increase that pressure. So we'll actually use 1 millimeter syringes to inject in the bone. But there's a strong correlation between these bone marrow lesions and the severity that we see in severe osteoarthritis. And then interestingly, cartilage doesn't have pain fibers. A lot of people think that if you have loss of cartilage, that's what's causing your pain. It's mostly water cartilage. But again, distributing those forces amongst healthy cartilage is great. But when you don't have that cartilage, that's where that subchondral bone is really going to take the brunt of the force. So what do we usually do for people that present to us with significant osteoarthritis of the knee? We'll tell them, well, modify your activities, try basic stuff like ice and heat. A lot of them have already tried anti-inflammatory medications or physical therapy. Sometimes they've had multiple corticosteroid injections. We now have enough data to say that not just the corticosteroid, but a lot of times what is also injected with that corticosteroid can really negatively affect that joint. I had a patient the other day that I saw the report for what was injected in a knee by another physician, and it was 1 cc of Kenalog, which is a corticosteroid, and 4 cc's of marcaine. And
Oh,
marcaine is certainly chondrotoxic, meaning it's going to damage the cartilage cells. So you might be actually advancing arthritis by injecting these types of things into joints. Hyaluronic acids, those are nice adjuncts because there's really not much downside to them. They're only approved for knee osteoarthritis, and sometimes that's worth a try, but it's not bringing really any cellular response that we look to try to improve the integrity of the knee. And then lastly, a total knee arthroplasty, a joint replacement surgery. And 4 out of 5 people typically get a good result with the knee replacement, but that means 1 out of 5 people are really unhappy with their knee replacement. And at that point, there's really nothing that we can do. It's beyond that. We can't inject something cellular based that's going to address the plastic and the metal that's in your knee. So what we do here is orthobiologic treatments, and we've been doing them for quite a while, and we've been collecting data on our outcomes. And we have a multifaceted approach when we look at a knee, a shoulder. It's really comprehensive. We're not just treating the joint, we're treating the surrounding areas. We're treating it as a unit. And what we offer is platelet-rich plasma. Some people have heard of that or maybe have had those procedures. Bone marrow concentrate, that's where we harvest your bone marrow and then we concentrate that down, and that's an aqueous solution that we can inject. And then MFAT, microfragmented adipose tissue, that's nice and rich with fat is the most vascularized tissue in our body. So these mesenchymal stem cells sit on there are pericytes that sit on these small blood vessels and then will turn into these MSCs. And Dr. Rogers, I'm sure you remember during these conferences, Dr. Arnold Kaplan, nice guy, who he coined the phrase MSCs, mesenchymal stem cells. And towards the end of his life, he wished he termed them medicinal signaling cells. And that's what they really are. They're very potent signaling cells. Some of my patients have probably heard me give the analogy that these cells are like the general contractor on a job site. They're going to bring in the other things. They're going to bring in the electrician, the plumber, everything to try to build that new tissue or potentially improve that joint.
yeah. Yeah, the mechanisms by which cells talk to each other is fascinating, and that would be a whole nother 3-day lecture. But essentially, the reason we like platelets or bone marrow cells or cells from fat tissue, particularly the mesenchymal stem cell, is because they are secreting molecules that augment healing mechanisms and decrease inflammation. That's essentially how orthobiologics work. Orthobiologic just simply means we're using a cell therapy to treat an orthopedic problem. So the cells are the platelet cells from your blood, the bone marrow cells from your bone marrow, or the stem cells from the fat tissue. And actually, I have Dr. Kaplan, who discovered the stem cell back in the 1980s. I have him to thank because more than 15 years ago, I was fortunate enough to have dinner with him, and he told me about the fact that fat tissue actually had stem cells in them, and that got me very interested, and it totally changed the course of my career. So I'm very grateful to Dr. Kaplan for that introduction to the world of stem cells.
So
Well,
what can
you
we?
you missed a good point, actually, you were going to make about how important it is to use image guidance.
Yes. Thank you. Yes, everything we do, there's no blind injections. That's really antiquated medicine. Sometimes I have people that come in and they had a failed PRP injection. I asked them, did they use ultrasound guidance? And no, they just kind of took a shot and hopefully got in the right spot. And I'm sure Dr. Rogers, they've done independent studies that looked at orthopods, orthopedic surgeons, and our specialty physical medicine rehabilitation and cadavers, and both got into the joint blindly in cadavers 80% of the time, which again means 1 out of 5 might have been in a fat pad or not in the right spot. And we want these to be really delivered to the right spot to get the best outcome.
Yeah, that's really quite a skill that each of the doctors in this practice have mastered, I would say. The ability to place a needle exactly where you intend to place it, do it in a safe and comfortable manner. And that's, I think, why our patients are so pleased, not only with the good outcomes, but with the fact that the procedure is not painful, because that image guidance is so helpful to us.
Yes. So we talked about what we can treat. We will treat the intra-articular, which just means in the joint. We'll treat that. If we see damage to ligaments and tendons, we'll treat that. But we can also treat the subchondral bone. So everything that we do, we want to have it be driven by evidence, real world evidence to support the things that we're doing for safety, for efficacy, to make sure that we're delivering the best possible treatment option that's backed up by data. So Dr. Hernigou in France, he probably did his first bone marrow intraosseous procedure. It's been over 20 years, and his data is fairly robust, and it's been replicated, and he took on a knee osteoarthritis patients with bone marrow lesions on MRI. He injected into that subchondral bone intraosseous, which just means into the bone, and he used bone marrow concentrate that was harvested from the same patients. And they wanted to look at, did this reduce the pain? Did it improve functionality? And did it slow down the disease progression? And so when it comes to the pain and functional outcomes, what they saw that there were significant clinical improvements in the VAS pain scores. And VAS pain scores is if you ever gone to a doctor and they say, what's your pain? Most places say like 1 to 10. And I always say 0 to 10 because some of our patients come back and they're zero. They feel great and they're having no pain. So on a 0 to 10 pain score, where do you lie? And we look at those numbers. So they saw a reduction in the pain scores, improvement in WOMAC scores. That's just a measure to look at pain, stiffness, and functionality in knee arthritis, and then activity tolerance and mobility. So they saw improvements in the WOMAC scores, and people had increased tolerance to activity and mobility. And so this led to the interpretation that treating the subchondral bone microenvironment helps decrease pain and improve the load distribution in dysfunctional osteoarthritic knees. When it comes to MRI findings, on subsequent MRIs, there was a reduction in the bone marrow lesion size, in some cases, partial or complete resolution of this marrow edema, and that correlated with symptom relief. In my experience, I usually wait at least a year after doing one of these procedures to get a subsequent MRI. And at that point, sometimes you do see a reduction in those size of the bone marrow lesions. I always tell patients I'm not after pretty images on the MRI, I'm after clinical results. So that's the first thing. If we see that backed up by changes in the bone marrow lesion size, great. But as long as the patients are having less pain, improved functionality, that's what we're after. So it is a treatable area for people that have severe knee osteoarthritis when they have bone marrow lesions. And then this is a really important point in that arthroplasty avoidance, trying to delay knee replacement. So 18% progress to a total knee replacement at 7 years. So that's quite a while for people to be able to get to that point, meaning that 82% were able to avoid a knee replacement at the 7 year follow-up. And again, there's been other studies that have had similar findings. Dr. Hernigou's data is the most robust on this topic. So treating the subchondral bone can help with pain, improve functionality. Sometimes we'll see MRI changes of these bone marrow lesions and hopefully delay or potentially avoid a knee replacement.
Yeah, it's really exciting to actually alter the course of osteoarthritis with so many years. I'm sure Dr. Marker, you felt this as well. So many years, it just felt like we were fighting the inevitable. We would do, like you said, corticosteroid injections, hyaluronic acid injections. These injections were not altering the pathology. They were not healing the joint. Whereas what you're talking about here, we're showing not only is the patient clinically improved, but we're actually showing changes on MRI imaging. And later we may discuss about how there's other studies that show that we're actually seeing regeneration of cartilage, things like this. So it's very exciting to actually have treatment options that heal patients.
Yes. Without the trauma of a major surgery. Yeah, it's very gratifying. So, what do you expect when you have an intraosseous procedure? I mentioned at the start that, again, once you mention that I'm going to be going into your bone, and that's usually where people cringe. But again, it's not so much the going into the bone, that it's more injecting something into the bone with that pressure gradient there. So it's a same day procedure. We either inject PRP, platelet-rich plasma, or bone marrow concentrate. It's always the patient's own cells, so chance for graft versus host disease is extremely low because your body's going to recognize those cells. If we do need bone marrow, that's harvested from the PSIS, the posterior superior iliac spine, or from the iliac crest. And I have a slide coming up that shows you where those areas are. So the injections can be done under full sedation. We have the ability to have a nurse anesthetist here. So you can have an IV starter where there's medications that kind of put you in like the twilight sleep. So some people, they like that. They just wake up and the whole thing's done. Otherwise, we can offer oral medications to kind of take the edge off the pain. I've found that over the years, working with the patient sometime, even on breathing, when I go to inject and I have them take a deep breath, and on the out breath is when I inject, and they're able to tolerate it pretty well. And we just do it slowly. You eke in a little bit of whatever you're injecting, whether it's PRP or bone marrow concentrate, a little bit at a time. There's no shot clock here. It's just we want to get as many healthy cells into that area as possible, and we want the patient to be comfortable. So this just shows the two areas. Typically, I'm harvesting from this area over here. This is that PSIS area here. And a lot of times we'll harvest from both sites to try to get the highest yield of mesenchymal stem cells. They sit right underneath that bone there.
Yeah, all your bones contain bone marrow, really, and in that bone marrow are a variety of different cells. But Dr. Hernegow, who Dr. Marker mentioned earlier, has demonstrated that the highest concentration of the cell type that we want, the mesenchymal stem cell, is located at that part of the pelvis. That's why that's our go-to site for collecting these cells.
So who's a great candidate for these intraosseous procedures? Patients that have persistent pain, usually we're treating the knees, but they can be done for other body parts. And then people that we see these confirmed bone marrow lesions on their MRI. And so sometimes patients are a little surprised when I push for an MRI a little earlier in the treatment process. They'll say, I've already had x-rays that shows that I'm bone on bone. And I'll say, I understand that, but I really want to see if there's the bone marrow lesions present, because this way I can give you a comprehensive treatment plan. I can treat the joint, treat any ligaments or tendons that need to be addressed, but also treat those bone marrow lesions. So it's usually for moderate or end stage severe joint disease. Mild to moderate knee osteoarthritis, PRP does an excellent job of that. It always shows up on the recommendations for what PRP can handle, mild to moderate OA. I'm sure Dr. Rogers, you've seen tons of home runs with that. But for the moderate to severe joint disease and people that are really trying to delay or potentially avoid a joint replacement, this is a really nice treatment option. So at this point, we'll open it up to any questions that the panel, that the people watching may have, or Dr. Rogers, if you want to add anything to the talk here.
So we've focused principally on the use of bone marrow cells for the use of for the indication severe osteoarthritis. I know you have some experience, Dr. Marker, treating other joints other than the knee, such as shoulder or hip. Can you talk a little bit about any experience you have with those conditions, or how maybe differs from the treatment of knee osteoarthritis, or is it essentially the same principle?
Same principle, just each joint has its own challenges. I would say the knee, from a procedural standpoint, are probably the easiest. because the areas that we're going to access is really close to the skin and with image. I've done these under ultrasound, but what's nice is when you have fluoroscopy like we have here, then you can use fluoroscopy and ultrasound. But typically, if I have access to fluoroscopy, I'll use fluoroscopy so that you can see. I kind of mark where those, excuse me, those bone marrow lesions are. Sometimes we were looking at straight on shots of the knee and those MRIs, but we'll want to correlate that with the sagittal cuts, which are side views, because you want to see, is that bone marrow lesion more anterior or posterior? I want my needle to wind up where that bone marrow lesion is. So, and a lot of times just there's a quick relief of just all the pressure that's built up in that subchondral bone. People feel better soon after. As far as recovery goes, one thing that I didn't mention, it's usually activity is tolerated. We'll send people home with crutches typically, but that's really just if they're sore. You don't really need to have to not weight bear on that. I certainly want to have patients go on a long hike or anything intense, give it several weeks to kind of do its thing. But these have been well tolerated in patients, octogenarians and beyond. So as far as your question, other joints, shoulders, you're going to go into the humeral head and then the glenoid part, a portion of the scapula where those two bones articulate. And then ankles, a little more challenging. There's a lot going on in ankles, whether you're getting into the talus and the tibia, but it can be done there as well. And same thing with the hip. The hips, I guess, a little similar to, it's analogous to the shoulder, and that we're going to go into the acetabulum and the femoral head. But well tolerated procedures. But again, we want to first do the workup properly to see if patients are a candidate for this.
So the first question, Dr. Marker, are orthobiologic treatments for thumb osteoarthritis on the horizon?
Well, not only the horizon, they're here. I mean,
Yeah.
we treat thumb osteoarthritis, CMC joint stuff all the time. So in the hand, these are very small joints. So the volume that these joints can accommodate in terms of fluid, whether you're injecting PRP or bone marrow, is pretty small. But usually I've treated some severe cases of CMC joint arthritis. I found for me, the best results I've had is doing a series of three with PRP and spacing them out. That especially for severe OA. You can do intraosseous stuff, but when you're talking about digits, whether it's feet or hands, you really need to use a smaller gauge needle to get in there. So it's not that you can't do it, but in those cases, I'll usually try treating just the joint first, and that would be my absolute last resort. But I see pretty good results with multiple PRP injections.
Yeah, thumb. I don't think people realize that arthritis in this little joint here, the carpal metacarpal joint, the acronym CMC that you slipped by us, CMC joint, is actually the fourth most common joint in the whole body. You have 200 joints. You can imagine what the most common joints are. The top three, hip, knee, and shoulder, but then the thumb is actually number four. You use that thumb a lot, and it's very, we see that commonly. And like Dr. Marker said, we've been doing that for over a decade and a half, treating that joint for over a decade and a half. And I think the other point I would add to your comments is you mentioned how important it is to have complete treatment. So we're not just treating the inflammation and the cartilage damage in the joint, but we're also looking at the ligaments and the tendons around the joint, just like we would any joint, because a lot of times they are involved as well, and they can be treated to get a better result and a longer lasting result. Dr. Marker, same procedure and etiology for severe hip osteoarthritis. So I think you addressed the issue of hip osteoarthritis. Do you have anything you want to add about the hip? Specifically, someone has a question about severe hip osteoarthritis.
Yeah, I chose to have this talk mainly about knee, but hip is probably the second most common area that we see such severe arthritis, and people are having arthroplasties on, and we're trying to delay or avoid those as well. So that's another reason why I'll push for hip MRIs to see if they have bone marrow lesions. And just saw one yesterday where you could see a really big bone marrow lesion within the acetabulum. And if you look closely, there was one kind of kissing it, meeting it at the proximal femoral head. So at that point, if they want the best outcome, I would treat both.
So both the socket and the ball,
Exactly.
basically. And That's good. We did this is maybe beyond the scope of the short lecture, but there's a condition whereby the bone of the ball, the femoral head, can become injured through a host of different mechanisms. And that's called avascular necrosis, where you have improper blood flow to the bone, and now the bone is dying. And Dr. Hernegal, again, our hero from France, orthopedic surgeon in Paris, has had great success injecting bone marrow concentrate directly into the ball of the hip. As long as the ball hasn't collapsed, in which point you're probably looking at a hip replacement, but as long as that ball is still round and intact, those early stages do well with bone marrow concentrate. And that's well published data. How do you determine whether to use bone marrow or PRP? Well, I think you addressed this. I don't know if there's anything else you want to add to that question.
Yeah, that's where the art of medicine comes into play. So for someone, if I have someone that's osteoporotic female, mid 80s, might not be the easiest to harvest the bone marrow from. I still see great results with putting PRP in there. If I'm going to use bone marrow in the joint anyway, then I'll harvest enough bone marrow so that I can put it in the joint and intraosseously. So it just kind of depends. We both have done tons of MFAT, the fat procedure that we offer. So for a knee, I might go into the joint with the MFAT. This way I'm getting it rich with mesenchymal stem cells, make some PRP, combine that into the joint, and then put PRP intraosseously. So this way we're doing two for one there. But that's kind of the art of it in deciding whose body habit is and physical status is best for PRP or bone marrow.
Excellent. I'm curious with the healing of the bone, Eric had this question. With the healing of the bone, is it the same time course as a lot of other conditions that we would see? Would you expect, for example, because bone is very vascular, do you expect to see healing of the bone sooner than you might see in a tendon or even with joint?
Yes, I'd say tendon is definitely takes longer. So I don't know about you, but when I do like an intratendinous procedure, particularly with like MFAT, I'm usually not wanting to do a repeat scan on the patient until about 6 months because it really takes a while for that new tendon tissue to be laid down. And you have patients that they want to see the changes but most of the time I say, let's wait 6 months and then you'll see a difference there. I usually don't order repeat MRIs just for the sake of seeing if the bone marrow lesion changed. Again, at a year, I might do it, and just because I want to see how things look and monitor progression of any of the disease process. But it does usually, the pain at least subsides much quicker than intratendinous procedures.
That's great. Well, we're running out of time here. I think this is a quick question. Somebody addressed the concern that orthobiologic therapies, although they're not new, I think you and I have been doing this for more than a decade and a half now, still not reimbursable by your standard medical insurance. However, all the other aspects, the evaluation, the imaging, the physical therapy, and bracing, anything else we might do that typically is covered by insurance, obviously, they'll cover those expenses. So it's just the orthobiologic therapy, the PRP, and the bone marrow and the adipose cells that are not yet covered, although that day will come, hopefully sooner rather than later. Um, I think you addressed most of the questions, and if anybody has any further questions that we didn't get to, or you think of something later, feel free to email us or call us. Our website is SDOMG, like San Diego, oh my gosh.com. Thank you, Dr. Marker, for sharing your experience with this innovative therapy. And it's just, one more tool in our toolbox that allows us to address this myriad of orthopedic conditions that we're able to treat. Thank you again.
Happy to do it. Yeah. Any questions, please reach out. And if we can be of help, we're here.
All right, everybody, have a lovely day.
Take care.
Bye-bye.